Ray Steinback is the head of the Echo Lab at St. Luke's, Baylor, and he is really an expert in VADS imaging. He was the chair of the writing group at ASE to evaluate ventricular assist devices. Ray, it's great to have you.
Thanks again, all the program coordinators, for asking me back for a case presentation. This is a case that I hope you'll find interesting. I enjoyed working it up. It's something I hope highlights a little bit about just how you can use modern imaging. This is a case that I actually just did a couple of weeks ago, in fact, and thought it would be interesting. I think what the fellow that did the case with me, I saw her in the audience back there. So we had fun with this. This is an 84-year-old male being evaluated for a TAVR, and he's got a 2-year history of multiple syncable and near syncable events, which for the longest time they'd blamed on sick sinus syndrome. He did have conduction abnormalities and had a pacemaker placed. But after the pacemaker, he was still passing out. He had exertional chest discomfort. He also was kind of a high-risk patient because he had past history of TIAs, carotid endarterectomy, so peripheral vascular disease. And he also had mild cognitive impairment, so advanced stage. He was felt by an outside C to TTE, transthoracic echo, to have aortic stenosis. His valve was severely calcified and had poor mobility, but they only could get a mean aortic valve gradient of 24 millimeters of mercury with a normal ejection fraction. So, of course, he came to us to assess him by TE to see if they could possibly be a candidate for a TAVR, since he's increased risk for surgery. He did have a left heart catheterization to check for coronary artery disease. The aortic valve was not crossed, and he had normal coronaries. And these look pretty good coronaries, I thought, for an 84-year-old who had endarterectomy, by the way. So we did the TE, and I just want you to take a look at these views. These are just some initial images. So this is a patient with possibly outflow tract obstruction, and I'd say this is like a 4-chamber and 5-chamber type view. And for those of you who aren't looking at TEs a lot, the left atrium on the top, the left ventricle, they're squeezing avidly, and you can see the left ventricular outflow tract. So I think in that left lower image, you can see there's some aortic regurgitation. Does anybody see anything else abnormal?
Anybody?
Anybody? I don't have an answer thing here. So just, does anybody think there's something funny in the left ventricular outflow tract? Yes. Okay, we can agree on that.
With you.
There's something there. But do you think there's obstruction in the LV outflow tract? I think just by looking at these images, do you think it's obstructed, LVOT? How can you tell? Yeah, so you see, if you look at the color Doppler image, of course, you're wondering if there's SAM or dynamic outflow tract obstruction, but we see nice laminar-looking color flow during systole in the left ventricular outflow tract. It's just the sample rate's not super fast in these loops. And I think it's, when you see funny things, it's nice to not just hone in on them, but do a sort of a systematic study. So I've gone around, we've had 4-chamber view, and this is sort of like maybe like a bicommissural view, which on the upper right, rotating the transducer just a little bit, if you have a bicommissural view, that's usually the same plane that you find the aortic valve in short axis. And so you can just kind of rotate a little bit. So I'm getting a view of the left ventricular outflow tract in the upper right. And then, of course, we've come all the way around to see the 3-chamber view, and you can see that AI jet in the lower right. And then there's still this character down in the outflow tract. Without blurting it out, does anybody know what this might be? You don't get to read because you've seen everything. Is it a what? You know, that actually came up in our TAVR meeting. People insisted that this was due to aortic regurgitation, and that he's probably had AI, and this could have resulted in an aneurysm of the mitral valve, and it was some funny. And then other people insisted that this is just a redundant cord, like this is a cord. We see that sometimes, you know, just like what we call chordal SAM, non-obstructive. Okay. That's not what this is.
That's not what
I think you know. Okay. This was my first one, by the way.
I mean,
This
for
is
you to
25.
be able to say that this is a redundant cord, right? You need to see a cord, right? So you need to be able to either scan it and see the attachment of this redundant cord from the papillary muscle being loose in systole and then going back and attached to the mitral valve. I mean, that's the only way you're going to be able to see it.
Make it
Most
a
likely
loop.
it's not.
Yeah, yeah, and also it looks like it could be a cord in the planar images, but then when you scan this in short axis, it's not a string. You know, it's a flap or something.
Right? It has some
I think it is interesting.
shagginess to it.
Yeah, I mean, I think it's interesting that the AI runs into it.
Right.
The question is, this is acquired or not? Okay, so we'll keep going. Now, some 3D, so we can't be in a meeting nowadays without doing 3D. I think the image on the left I find less helpful, except that I didn't really scan the mitral valve a lot, and I think it's important to know whether there's MR, and I think here you can see there really was not any more MR than what we're seeing here, just a little trace of MR, and if I really thought there was SAM here, like with the case that Carla showed, I mean, a lot of times that severe SAM is going to cause some eccentric MR. I'll say that image on the right looks super ugly and furry, and like the gain looks like it's messed up, but I think this is what I do sometimes if I'm trying to image in 3D things that are very, the spatial resolution's really small. Like if you turn the gain down on this, you can't see what look like the chords. They just kind of disappear, like that image on the left. So I think sometimes over-gaining it, if you're trying to see small, thin objects might help in part of what you're doing imaging-wise. So again, it looks like a variation of what we saw in the 2D image, right? Anybody else have it? He still got it. Okay. All right. And I thought this was, in the TAVR meeting, they kind of went crazy when they saw this, and just like, I had to be honest, I wasn't sure what it was, but the nice thing about this image is it's an inverted surgical view. So we're seeing the mitral valve in short axis view. And there on the left, you can see the two leaflets. So this is sort of a bicommissural view, and you can see the posterior leaflets on the top and then the anterior leaflets on the bottom. So clearly you see this tongue-like structure, you know, sticking out under the mitral anterior leaflet into the outflow tract. So how many of y'all have seen this every now and then? Okay. Well, the big question was, are we going to go stick something through this aortic valve and into the left ventricular outflow tract to do this? And we still haven't gotten to the main, you know, I haven't even shown you whether he's got severe aortic stenosis yet or not. But look, the gastric view, which we talked about earlier, is the way that we really look at the outflow tract and get some Doppler measurements. So here we've gone down, and a lot of times you can get, just on the planar image, a nice view where you can see all along the mitral coaptation zone. So you can see the anterior and posterior leaflet coapting there and making a little smile, and then the LV outflow tracts towards 7 o'clock. And look at the right, it's just getting a little bit more of a slice thickness going below the mitral leaflet. You can see it coapt, but then there's this structure below it. It looks kind of, I don't know, how would you describe that? Like a little cystic or saccular or, okay. How many of y'all have seen this happen before? Now, the other thing to think about, sometimes we get really aneurysmal basal mitral anterior leaflets if there has been endocarditis, but those tend to be aneurysms that protrude up into the left atrium and that not distal to the coaptation zone. I have kind of not seen this before. And this is another gastric view, and this is just to show where the mitral coaptation zone is. If you look at the lower left, you can see where that upper arrow is. That's where the mitral anterior and posterior leaflets are coapting, and then you've got this thing down in there. I found it a little hard to make out. So, now the other question was, does the guy have severe AS or not? And he did. We did planimetry of the aortic valve, upper left. It was around 0.9 centimeters squared. And if you looked at a post PVC beat, we could get a mean gradient of 40 millimeters of mercury, so that would kind of put him in that severe range. It looks like late peaking, and we are a little bit off axis, and I can tell that because the Doppler profile looks two-toned. So we gave him, his dimensionless index was less than 0.25, so I think he met criteria for severe aortic stenosis, and he's symptomatic. He's got a fair amount of AI, so I think he probably would benefit from a TAVR if we just knew what that other thing was, and would it be okay to do the case. So what do people think? Would you be afraid to do a procedure in this patient, or just kind of plow ahead?
Looks like it's safe.
Yeah. You haven't seen the result yet. I should have held this slide. So what do we see? So this is so it's multimodality imaging, good old-fashioned fluoroscopic image, and there you can see the T probe on the left, and there's a pigtail down in the coronary cusp, so we're sizing, we're directing where the device is going to be, and here it's on the right, there you can see the cage is deployed, so he got a sapien valve. So this brings up the other point. I know we were talking about before how our use of transthoracic echo in TAVR cases is really the norm in our lab also. We feel pretty comfortable with that, but this is a case where we did use transesophageal echo just to kind of make sure, what if we harpoon that thing, what would happen? So we did have the T probe in there, and they were careful to kind of go around it. And so the device went in just fine, but we still, didn't really know what the guy had. And so that was the question. I had lots of peanut gallery diagnoses. And so the device went in, and you can still see it there. See it in the upper left. We see that when you turn on the color, I think there's some AI, which I think this is catheter related, because this is with color Doppler with the device, with the guide catheter still in. There was no perivalvular AR, but see there's still that thing in the outflow tract. Yeah. And this is actually an image done at the time of deployment. I thought it wasn't done by me, but you can see this from the gastric view. We're looking from the ventricle towards the mitral valve coaptation zone, and notice that the gains are all perfect. So to look at the leaflet tissue, but we've turned the gains down so that you can't see the chordae anymore, and so that you can see this tongue-looking thing going towards the outflow tract, which there is the outflow tract's pointing towards the lower right.
It's so complicated.
Okay. And the interesting thing to me also was before the guy went home, this is a repeat. We didn't actually have the outside surface echo, at least I didn't. He wasn't my patient. And so we got these images, and it's surprising to me how, it just doesn't show up very well here. You look at these standard parasternal long axis view, short axis view, and it's like a little blip there. And I started wondering, maybe I've missed a few of these over the years and just wrote them off to being a redundant cord. So what's the diagnosis besides the one person in the room?
Well, I would say this is a congenital anomaly.
Okay, say who thinks this is congenital versus acquired?
Yeah, I would say congenital.
Okay, acquired.
I think it's a cord that never finished the job.
A cord that never finished the job.
That would be my...
What is the job?
So it could be
The last 3D that it did was really, that last 3D was so nice. It looked like it is attached to the valve.
Yes.
But it never gets attached to the papillary muscle. So it just hangs in there. It's like, it just by nature, it just never made that connection. That's my...
So you think it could be some looped chordae or?
But congenital, not because of any
Yeah.
Arcade mitral.
What do you
That's why
think?
there's
I
no
think
mitral
it's
regurg. It's not something like a rocky cord that's not there.
something called.
Right. Yeah, no, it's interesting to me. I mean, the valve functioning pristine. So anyway, any other guess?
What about the? I mean, I was thinking about that. There are two things that come to my mind. One would be that sort of part of a rudimentary papillary muscle attached to the mitral valve. There is something called arcade mitral valve that could be that. And the other one, at one time I saw this little nodular with, I was thinking if this could be a fibrillastoma of the mitral valve.
I think it's either a really redundant chordae. Let me tell you, the way I assess it here from this view and the other views is that it is not completely loose.
Yeah.
Meaning, in systole, if it was completely loose, you will see this thing flinging much faster. So it is still attached to something,
Yeah.
right? It's not only attached to the mitral valve, it's attached to something below it. For it to give it this rather stable during a very high flow situation in the LV outflow tract situation. So either redundant chordae or a fibrillastoma. You know, I mean, I can't see it too well here, but
It's
Thin for the papilloma. I think it's a cord.
yeah.
Yeah, I agree with you.
It's
Right,
got-
they have an attachment still, and it's an attachment somewhere. It's not-
okay. All right.
Steve, what do you think? Or Carla?
That one 3D image that you had of the mitral valve where it looked like it was a little goatee underneath underneath that leaflet. I mean, that was so convincing, and it was kind of that one. And it was
Convincing
kind
of?
of fat, and it looked fatter than what you'd expect a chordae to be. And you said you had suppressed the chordae, so that's where I was like, I don't know if this is really a chordae. And I was voting more for a papillary fibrillastoma. And I would say, did you get the CT image to look at it?
No, we didn't get a CT image.
See,
I-
too fast moving.
Too fast.
I didn't really figure this out until I really had to think about it. And I think I know what it is just because we published one of these in the.
Can you ask? Let's see, Steve.
Steve, go
let him
for it,
commit
yeah.
himself.
Well, I agree that it's a goatee. Now, this is actually a less impressive than most accessory mitral leaflet.
Accessory mitral leaflet.
Really?
I knew he would get it.
Wow.
So let's take a walk.
Often they're much more florid. They can vary. They can look string-like. They can be bulkier. The main worry is LV outflow tract obstruction because they can be very prominent and obstruct LV outflow tract. This one doesn't. Some people said they can be embolic. I don't know if that's true or not. But basically, this one, I think it's incidental. And I think you were okay to go ahead and do your TAVR.
Yeah. Okay. Well, let's walk through the literature because there's not a lot of it. But interesting, I couldn't convince anybody what this was because I thought it was the same thing, accessory mitral leaflet tissue or accessory mitral valve. And so if you just know what to call things sometime, then Google's invaluable, right? But if you don't know what it's called, then you're kind of stuck. And you can kind of but that's what it looks like. And the question is what exactly is this? So this is a small case series that came up in the, European Heart Journal, CV Imaging a few years ago. You can see Bijoy Kandaria is actually one of the authors, so sanitized it so that is probably accurate. And so this is just 3 cases that they showed similar masses. This is a 30-year-old female that had atypical VT, and during the workup, they found this cystic-like mass attached to the mitral leaflet, no impairment of function, no outflow tract obstruction. We don't have movies. But again, if there's something funny down associated with the mitral valve. And then their other case, a 22-year-old male with a bicuspid valve, coarct repair, serpiginous structure that changed shape during the cardiac cycle. in some forms, and some frames it looked like a circular ring. Now, they didn't really have 3D echo, but you can see there's something floppy and moving around in the left ventricular outflow tract. I was very not convinced about this particular case because to me it looked like SAM, but I could not really see what the structure. Sometimes with SAM, the mitral valve can kind of double back on itself. So at any rate, accessory mitral leaflet tissue was reviewed here. So there only were 104 case reports from 1963 to 214 on this, and less than 30% were in adults. So it's to see this is pretty unusual, and it's usually incidental. There are associated malformations that you should look for if you see this. Our patient didn't have any, but VSD, ASD, TGA patients might have it. It's rare regardless. And then you only need to do surgery if you're repairing an associated anomaly or if there's outflow tract obstruction, and it can cause outflow tract obstruction. And their cases also highlighted the usefulness of TEE to look at it. And this is from our new journal case that the ASE does. And in first year of publication, this is like one of our first cases reported, a 52-year-old obese male with exertional dyspnea that had actually nothing to do with his heart. Very functional mitral valve with no MR or MS, but had this like snaky-like lesion associated with the mitral valve on multiplane imaging. But again, no 3D image or surgical. But I love this report by Julio Perez from 2005, where they had a series of patients, and two with actually surgical specimens, mitral valve accessory tissue, just as was noted, and these have the same characteristics as leaflet tissue and chordae, but they're just malformed. These are described as being pancaked onto the anterior leaflet. They just had 5 cases. Cystic structures, they look like little parachutes sometimes in these chordal type attachments. They can be variably web-like, but they're attached to either the papillary muscles or the backside of the anterior leaflet or other places. There's just not enough reports really to have something uniform. But what he did notice that in their lab, they had 5 cases diagnosed over 6 years that they actually came to their attention. So that means 1 in 26,000 echoes. And I just think, is this like another one of those things that with better imaging recognition, maybe they're more out there than we think. They're just kind of funny looking, especially the ones that don't go all the way into the outflow tract. This is a case I also liked, is from Japan, 2004, and you can see there, this is a case that the structure is in the lower right, and you can see there before and after surgical resection in image A and B in the middle on the top, there's a severe outflow tract obstruction. So this little parachute-like extension of the mitral valve was attached below, just like the one from Dr. Perez's lab. So this is also the case that one of our former fellows published here in Texas a few years ago, and this is non-obstructive accessory mitral valve that they recognized and just treated medically, and this was the first case that I was really made aware of. And so this was a 53-year-old female. They recognized it, did some research and published it, and the patient was doing fine 3 years later. It didn't progress. So looking back at ours, I think you can see this. To me, it looks like it might be one of those parachutes. It's not a circular one, but you know, those square ones that you see, those parasail type things. And you can see how it might have an attachment that in maybe a couple of places it might look like that one from Julio Perez's lab. So here you see it. And so this is usually as an incidental finding. And now here to me it looks more like a dragnet, you know, something from behind a race car, just kind of attached to the papillary muscles. And you see how that likely is just a little patch of leaflet tissue attached with cords that we saw. So I thought I would just share that with you guys, and maybe we'll see some more in future years now that we can see things better in the heart just generally. And so it's rare, and it should be considered in the diagnosis of LV outflow tract obstruction, although it can also be without. And 3D can help define this confusing anatomic structure and consider associated malformations. I think it's just nice to have seen one of these because they happen. And thank you very much.
Thank you.
Okay.
I mean, this is very informational, Ray. Thank you for sharing it. I can tell you from my own experience, I never called them accessory mitral valve tissue. We've had one with obstruction, significant obstruction actually, and probably one or two without. At least that's in my experience. Miguel, you've probably seen. I mean, I called them accessory chordae first.
We were all saying the same thing.
Yes.
We were saying congenital, it's part of the mitral valve.
Yeah.
something
Right.
else. But the terminology, I think it's nice to have it.
Yeah.
Accessory mitral valve.
That's very
Yeah,
interesting.
so in a lab
Questions?
like this, I mean, you should see one every couple years or something like that.
Questions from the audience. Have you guys, anybody of you seen something like this in your experience? You got one over there, two maybe. Yeah, it's going to be rare, but we have a name for it now.
But also, I think it's just nice. It's an imaging course, so like I really took all the images for me to sort of wrap my mind around what it was. So, thank you.
All right. Well, thank you very much, Ray.